निर्भय
भाई ये YouTube पे खाली मैं दिख रहा हूँ।
A very good afternoon to everybody. I'm Dr. Azmi Mohsen, faculty at Nextillo. Very thankful to this Nextillo team, the co-founders and our director, Dr. Sunil Sharma sir, for providing us this platform to share our knowledge with the medicos throughout the world. And also Dr. Nachiketa sir to sharing with this knowledge of surgery and combining it with my lecture here. So this topic today we are going to teach you here is thoracic inlet. Many guys, you must not be familiar with what is actually thoracic inlet and thoracic outlet. You must be having these doubts. So you'll get it clear today. Just stay focused. I'm going to teach you about this thoracic inlet because as a part of anatomy, we consider it thoracic inlet, the upper brim of the thoracic cage. But there is something which is called thoracic outlet as well. And that Dr. Nachiketa will be telling you because that's a part of surgery. So stay focused. We're talking about thoracic inlet now. So here you're seeing this is the rib cage, right? And the upper limit, which is truncated, like thoracic rib cage is a truncated cone sort of thing with a narrow inlet, this brim of thorax, which adjoins the base of the neck. That's called the thoracic inlet, right? Can you appreciate the inner red color margin? So this is a thoracic inlet, and you can see it's a tilted thing. It's not a horizontal inlet. It's an inclined. It's a depression. It's the anterior portion is depressed down by around 3.7 centimeters. And the diameters here, you can see it is not a circular thing. It is a reniform or a kidney-shaped inlet. The anterior-posterior diameter is around 5 centimeters, and the transverse diameter is around 10 to 12.5 centimeters. So that makes it a reniform thing because posteriorly there's a bulge of this first thoracic vertebrae. So that's the inlet of thorax. And you can see that this inlet is not actually completely an open thing. It is being partitioned by this diaphragm of the inlet of thorax. And that's formed by Simpson's fascia. Here you see is the Simpson's fascia, or the suprapleural membrane, which bridges this thing and only leaves a cleft-like opening in between behind to the sternum, reaching up to the thoracic vertebrae behind. And that part provides a passage for the structures to move inside the thorax, and as well as for the structures to emerge out of the thorax. So this is the thoracic inlet we're going to discuss here. To have a lateral view or a sagittal view, you can see here, this is the manubrium, right? And this is the upper thoracic spine. So what you find is that this first rib, which is a horizontally lying rib, right? And it's an atypical rib. So the anterior costal end of this first rib, it adjoins the manubrium, and posteriorly the head end of the rib that articulates with the first thoracic vertebrae. So and you can see that this posterior end is elevated above, right? So the anterior end of this first rib, it in horizontal level, it lies opposite to the third thoracic vertebrae. Okay, to understand it better, now look here. This is the manubrium, and manubrium posteriorly, lies in front of the third and fourth thoracic vertebrae, and that's the area of the superior mediastinum. This is called the superior mediastinum. And the upper brim of this suprasternal notch, this is the suprasternal border with the jugular notch here, and this horizontally lies in front of the upper border of the third thoracic vertebrae. So that means this inlet, this is the inclination of the thoracic inlet. So the first rib reaches to the first thoracic vertebrae. So what you find is the thoracic inlet is dipping down by around 3.5 centimeters, which make it an angulation of around 45 degrees with the horizontal. That's how it's inclined. And just because I've got across to this figure of 3.7 centimeters in anatomy, you will come across two more structures which are around 3.7 to 3.8 centimeters. One is inguinal canal, don't forget, and the other one is anal canal. So here you got the same another figure that is the same, and that's this anterior end of the thoracic inlet. It dips down by 3.7 to 3.8 centimeters. Okay, now you were seeing here that this is this inlet, and there are structures which are reaching inside. One is the food pipe, the esophagus, then the windpipe, trachea in front of it, and this is the jugulars, the common jugulars, subclavians with joints to form the brachiocephalics. So the brachiocephalics are the vessels to enter into the thorax. And what is emerging out here is the brachiocephalic trunk or the brachiocephalic artery from the right side. And on the left side, it is the common carotid and left subclavian. They are direct branches from the arch of aorta. So these are the structures. They're large structures, but there are so many smaller structures as well, which I'll be covering up. Then you also see on the two sides is the apices of the lungs. Now these apices, so remember now the lungs is not completely a structure of thorax. It encroaches within the roots of the lungs. It encroaches in the roots of the neck. And when the apices of the lungs reaches to the root of the neck, they are covered by a rigid, tough, inelastic diaphragm of the inlet, and that's called Simpson's fascia. Okay, let's see now the next slide. Now we're talking about the diaphragm of the inlet thorax. So you seeing those so many structures emerging out here, and all of this is covered by a green color thing. In the next image you're seeing is the suprapleural membrane, which you also call it as Simpson's fascia. It's a rigid, inelastic, tough, fibrous membrane with its base direct attached to the inner border of the first rib and its cartilage, and its apex reaches to join the transverse process of the 7 cervical vertebrae. So it makes it somewhat a triangular diaphragm, right? And this morphological significance, let me tell you that it is presumed to be a degenerated muscle, and that is scalenus minimus. Now, scalenus minimus, when it degenerates, it forms the suprapleural membrane. This is also called as pleuralis, right? And now you see in a transverse section, what lies below to this membrane, immediately below to this will be the endothoracic fascia, as well as the cervical pleura. The parietal pleura gets a different name in different regions, like the costal pleura, mediastinal pleura, diaphragmatic pleura. So the parietal pleura covering the apices of the lungs is called cervical pleura, and that cervical pleura gets tethered. It sticks to the undersurface of the suprapleural membrane. So now you got to know, when you inhale, deep inhale, so your lungs expand, but you don't find the puffiness or the bulgings on the root of the neck, just because this is the diaphragm which prevents the bulging of the lungs in the neck. Now, here you're seeing is the two muscles here, which are, this is the upper surface of the first rib, and you see the inner border of the first rib has a tubercle anteriorly, and that's called scalenii tubercle, onto which there is insertion of this muscle, scalenus anterior. And posteriorly on the upper border of the first rib, you find is the insertion of scalenus medius. There's also a muscle called scalenus posterior, but that is attached to the outer border of the second rib. It's not related to the first rib. So we'll just focus on scalenus anterior and scalenus medius. So this scalenus anterior and medius, this provides a passage for the subclavian, both the sides, subclavian artery as well as the trunks of brachial plexus to emerge out. And one more thing is, all these muscles, scalenii muscles, they're anteriorly covered by a modification of the deep cervical fascia, and that's called prevertebral fascia. So all this thing is like invested by a prevertebral fascia. Now these images, when they these structures, subclavian artery, which will continue as axillary artery, the trunks of brachial plexus, which will continue as cords, and then the branches, all of it is this, it carries this prevertebral fascia along with it, and that's called axillary sheath. So remember, this has been commonly asked in various exams, that what is axillary sheath? Is it a continuation of the prevertebral fascia and invests this brachial plexus as well as the axillary artery. What you're finding here is that this subclavian vein, now this subclavian vein is crossing the first rib anterior to scalenus anterior, right? So this will be outside the axillary sheath. Okay. Now here in this, we'll be talking about the structures emerging out here and reaching inside. You have already seen this is esophagus, trachea, then this brachiocephalic trunk on the right side. Then you have left common carotid, left subclavian, then the two brachiocephalics, which are formed by the joining of this internal jugular and subclavian veins. See, these are the two brachiocephalic veins, as well as the vagus. Remember the cranial nerve, the vagus will also descend down and will reach and will descend on the two sides, the trachea. Then you have phrenic nerve, as well as the, this brachial plexus. If it's asked, like, brachial plexus is not only the content of the neck, because remember, there are 7 cervical vertebrae. And how many cervical nerves you have is 8. You have 8 cervical nerves. So in case of cervical nerves, each of the cervical nerve that will emerge above to their numerically corresponding vertebrae from the intervertebral foramen. So C7 emerges above 7 cervical vertebrae, and C8, this nerve will emerge below to 7 cervical vertebrae. So from where will this T1 emerge? T1 will emerge from below the first thoracic vertebrae. And that's how from thoracic onwards, all the thoracic nerves, all the lumbar, all the sacral nerves, they will emerge out from below to their numerically corresponding vertebrae. So only in the cervical spinal nerves, they'll emerge from above to their numerically corresponding vertebrae. And this pattern is changing because you have 8 cervical nerves and 7 cervical vertebrae. Hope you remember this. Now think about the T8, the C, T1. T1 contribution to brachial plexus is from within the thorax, because this inlet of thorax is reaching up to the upper border of T1 vertebrae. And T1 spinal nerve is emerging below to T1. So T1 actually is a content of thorax, and it will ascend up, it will climb up to the first rib, and then it will join with C8 to form the lower trunk of brachial plexus. So the lower trunk you will find is jumping. It's taking a high jump. It will cross to the upper border of the first rib that way, right? So in case there might be a cervical nerve or cervical rib. So in case of cervical rib, this lower trunk of brachial plexus will take a high jump, will have to take a higher jump. And that's a case where you can have this lower trunk of brachial plexus and will be under stress, will be stretched. And in case of cervical rib, the subclavian also will have to take a higher jump, or it might be compressed. It might be passing above to the first rib, or might be passing below to the rib. So that will all be discussed later on. You just keep on focusing on the structures you are seeing here in the inlet. And of course, you find is the two lungs, apices on the two sides. Okay, now talking about the detailed structures here. Passing through the inlet, you can see it's a reniform opening. This is the transverse diameter around 10 to 12 centimeters. Anteropostally, it is 5 centimeters. And now you focus upon, because many times they might ask an MCQ, what are the structures passing, all except sort of thing, structures passing to the inlet. And I remember there was this one question in Rajasthan University of Health Sciences regarding to this thoracic inlet. So now let's see in the midline structures, you will find just behind the manubrium is the remnants of the thymus, right? So remnant of thymus you find just behind to the manubrium. Then you find is this, trachea. And then you find behind is the esophagus and the infrahyoid group of muscles, the strap muscles. Sometimes they might ask different type of, bipinnate, unipinnate, multipinnate. So strap muscles also. The examples of strap muscles are the infrahyoid group of muscles that include here, anterior most will be the sternohyoid, right from sternum reaching up to the hyoid. That will be the anterior most. And deep to that will be sternothyroid. And this sternothyroid again continues above from thyroid to hyoid in form of thyrohyoid. You have 3 muscles just here in front, and these are the strap muscles. Sternohyoid, then you have below to have sternothyroid, then thyrohyoid, and another then coming from the superior notch, and that was omohyoid. So those are the strap muscles. They are innervated by the ansa cervicalis. Deeper to the thymus, you find is the inferior thyroidal veins. Now, these inferior thyroidal veins, they drain into the left. Hello.
हेलो क्या हुआ?
I think network issue था. Hello. So are you connected, everybody? So we were I'm correlating the relevant points for your MCQ purpose. So stay focused here. So all what you can, get questions regarding this is what I was telling is right and left brachiocephalic, which is the longer vein, right or left brachiocephalic. Obviously, the left brachiocephalic will be longer because it reaches onto the right side and then joins to the right brachiocephalic and left brachiocephalic together join to form the superior vena cava behind to the manubrium. Then you find is the brachiocephalic artery on the right side, but on the left side, you have 2 different vessels. That is this common carotid, left common carotid and left subclavian. What else you finding here is the internal thoracic artery. The internal thoracic artery they are branches from the first part of the vertebral artery. Then they have not shown here. You will also find is, this superior intercostal artery. Actually, superior intercostal artery, they have shown here, it is the first posterior intercostal artery. So superior intercostal artery is a branch from costocervical trunk, and which provides this first and second superior intercostal, posterior intercostal arteries. Then you find is right and left vagus. They descend down on the two sides of the trachea. Then you have right and left phrenic nerves. Phrenic nerve will descend down along with this anterior to the scalenus anterior and will accompany an artery that's a branch from the internal thoracic artery, and that's called pericardiophrenik artery. So phrenic nerve, pericardiophrenik artery, they together descend down and they cross to the mediastinum anterior to the hilum of the lungs over to the fibrous pericardium. Then you find is the thoracic duct. Thoracic duct is exceptionally thin, which you find only on the left side in this portion. But remember, the thoracic duct, half of its course is like from the aortic opening. When it ascends up, it ascends onto the right side of the spine up till the fifth thoracic vertebrae. Then it crosses the fifth thoracic vertebrae and reaches onto the left side of the spine. So it crosses the thoracic inlet, then arches, and then drains at to the junction of this, left internal jugular and left subclavian, where it drains. This thoracic duct drains there at the junction of left internal jugular and left subclavian. Then these are longus scoli, which joins the head of the first strip to the first thoracic vertebrae. Posteriorly, you'll find is the sympathetic trunk also. Then, of course, the first posterior intercostal vein, both the sides, they drain into the corresponding left brachiocephalic vein. Here you're finding is superior intercostal arteries and the first thoracic nerve. So first thoracic nerve, remember, in case of brachial plexus also, I just told you that the first thoracic nerve will ascend up to the first rib and will join CA to form the lower trunk. On the two sides, you find is the apices of the lungs, and they're covered by this cervical pleura. So these are the structures you're finding. They're passing through this inlet of thorax. And in case of MCQ purpose, this I have included is an image. You can see what lies just behind to this this sternoclavicular joint, both the sides, is this commencement of right and left brachiocephalic veins. In case if they ask what lies immediately behind to the upper half of the manubrium, then it is this left brachiocephalic vein. What lies immediately behind to the lower half of the manubrium, it is this arch of aorta. All right. So these are few MCQs which might be asked, and I'm very sure that you might not be, some of those who are beginners. So I would suggest, because these are all just images taken from the different books, what I would suggest, if you want to follow my handmade diagrams and detailed lectures for the beginners, I have uploaded all my lectures in detail, extensive lectures in those who are freshers, and even for those who are preparing for PG exams. You all should join this Nextillo app, right? And recently, these co-founders and director, they have given this helping hand program because of these, crisis, international crisis. So those people who are sitting back at home, they subscribe to this Nextillo app, and at only ₹89 for 3 months. This is a very good offer for you all. So do subscribe to this app and stay connected. There's many extensive lectures, not only from anatomy, but from all the 19 subjects of medical science. So it's a very lucrative offer. Please grab this offer as soon as possible. And let me continue with this lecture first. Here you're seeing is the two muscles. One, you can see this tendon. Can you see this tendon attached to this, about the first strip? This is scalenus anterior tendon, which has been cut out. And behind you seeing is this muscle, scalenus medius. Now, in between scalenus anterior and scalenus medius, on the upper part of the first strip, there's a gap. And that gap actually is called thoracic outlet. What you're finding is this subclavian artery, which after crossing the outer part of the first strip, it gets a new name, and that's called axillary artery. So remember, what is axillary artery? Is nothing but it's a continuation of the subclavian after crossing the outer part of the first rib. And then you're finding is the trunks of the brachial plexus. And remember, you can see here what I've shown here. This is pectoralis minor, right? And behind to pectoralis minor, the portion of the axillary artery is called the second part. So in case if it's asked, like, this lateral cord of brachial plexus, medial cord, lateral cord, posterior cord, how do they get names? So these names, lateral, posterior, and medial cord of the brachial plexus, they are the names given in relation to the second part of axillary artery. So here you're seeing these are so closely applied to the second part of the axillary artery. What is this nerve passing below to the suprascapular ligament? This nerve is suprascapular nerve arising from the upper trunk of brachial plexus. All the relevant things which I could complete here in this limited time, I have tried to express it. So, and one more thing here is the cervical rib. This is, I would say it's not very rare. It's like 0.5% in human population, or like 5 people in 1,000 might be having this seventh cervical rib. So in case with this cervical rib, this will entirely join to the manubrium. And what will this lead to? It will actually lead to narrowing of the thoracic inlet. First thing is that, and it will also lead to trunking, narrowing and tilting of this inlet. So there will be obviously the chances of neurovascular compression, especially those big vessels. The subclavian will have to arch above to this. If it arches above to this, it will undergo stress. The the T1 spinal nerve will join to this lower trunk, that also will be under stress. And if this vessel passes, subclavian vessel passes below to the cervical rib, then also there are chances of compression of this vessel. And all this will lead to, weakening of the muscles innervated by T1 spinal segments. Those are the thenar group of muscles, and most of the intrinsic muscles innervated by ulnar nerve. So all the neurovascular, and remember the autonomic fibers passing also to this, and one more important, this sympathetic fibers ascending up to this lower trunk of brachial plexus, reaching to innervate the orbits, and that might also lead to Horner syndrome. So Horner syndrome and thoracic outlet, that will all be taught to you in detail by Dr. Nachiketa sir after this. And finally, this is the again I'm recommending you to subscribe to this Nextillo app under this FMG. If you download this app, and in the FMG section you will find there is a helping hand program. This offers you a 3-month subscription for only ₹89. So join this, and thank you all. Now Dr. Nachiketa sir will continue with you all. Okay.
Thank you. Screen sharing those are made. Hello. Hi there, a very warm welcome to all of you from the team Nextillo, and special thanks to Dr. Sunil for sharing this wonderful platform with all of us. So now let's Dr. Mohsen has just explained to us in great details about the thoracic inlet and the outlet. It was a wonderful lecture, and we shall be continuing taking over from there itself. So now let's come to and talk about the thoracic outlet syndrome. Before going into the thoracic outlet syndrome and the thoracic outlet and explanation of that, I would just like to recommend to all of you to subscribe to the Nextillo Helping Hand plan, which gives us access to the app for only for 3 months. Okay. So now coming to the thoracic outlet syndrome. Now, as Dr. Mohsen has just told us that what actually is this thoracic outlet. Now you can see here in this picture itself that this whole area from where this artery and these nerves of the brachial plexus are coming out is the thoracic outlet. That means this whole area from here up to here, where the nerve and the artery enter into the axilla, this whole area. And while passing in through this whole area, the so-called thoracic outlet, there are a number of things that may happen to these structures. Now, this thoracic outlet in itself can be divided into three functional areas. The first important three of these three functional area, or the three component of the thoracic outlet, is actually the interscalene triangle. As Dr. Mohsin told us, that this is the scalenus anticus, or the anterior scalene muscle, which is going to the first rib, and this is our middle scalene muscle, which is once again going and inserting on the first rib. And down here we have our first rib. This triangle that has formed over here is known as the interscalene triangle. And as you can see here, through this interscalene triangle, this subclavian artery and the branches of the brachial plexus are coming out. The second important area that you see here, just in front of the anterior scalene muscle, we have the subclavian vein here. This subclavian vein is passing anterior to the anterior scalene muscle and below the clavicle above this first rib. This area of the thoracic outlet is what is known as the costoclavicular space between the clavicle and the cartilage of the first rib, the costoclavicular space. That means here in this picture, this is the clavicle, and down here we have the first rib, which is going back down here like this, and this vein is coming out between from these two areas. These two structures, the nerve and the artery, they are coming in between the scalenus anticus and the scalenus medius muscle through the interscalene triangle. Okay, and when these structures come out over here, and the vein which is passing from here inside into the thorax, ultimately they enter into the axilla below this pectoralis minor muscle, below the coracoid process, from where the pectoralis minor originates. This area is what is known as the pectoralis minor space, or the subcoracoid tunnel, or the subcoracoid space. So mind you that this whole area, the thoracic outlet, has got three components. First, interscalene triangle, then we have the costoclavicular space, and then we have the pectoralis minor space. And a compression of these structures may precipitate at any one of these 3 points. It may be in the interscalene triangle, it may be in the costoclavicular space, or it may be in the pectoralis minor space. We can have a better view of these structures over here in the next picture that I'm going to show you. This one. You can see here once again, this is the pectoralis minor. Sorry, this is the scalenus anticus. This is the scalenus medius, and between these two we have this triangle. The same here, scalenus anticus, scalenus medius, and through the triangle coming out these two structures, the nerves and the artery. And then going in below the clavicle and above the first rib here in front of the scalenus anticus, we have the subclavian vein going. And then below the pectoralis minor, all of these three structures we can see going into the axilla and then ultimately passing in through the upper limb. So furthermore, now what is happening here? That through the interscalene triangle, this triangle that we have passes two structures, the nerves of the brachial plexus and the artery. The vein does not pass in through the interscalene triangle. It is only the nerve and the artery. The vein passes through the costoclavicular space. So through the costoclavicular space, the subclavian vein passes. And ultimately, all of these three structures, they pass in through the pectoralis minor space. Fine. So this is it. The whole important anatomy, as Dr. Mohsin has already explained to us. These were just some surgical details about it. That what is the interscalene area, what is the costoclavicular space, and what is the pectoralis minor space. Because we will call the syndrome with the same names. So we need to remember these names and the areas. So now this thoracic outlet syndrome, what is it? The thoracic outlet syndrome actually is a very broad term which refers to the compression of the neurovascular structures in the thoracic outlet, be it the nerves of the brachial plexus, be it the subclavian artery, or be it the subclavian vein. The compression of these structures together or individually is known as the thoracic outlet syndrome. Dependent upon which structure of these three is compressed, the thoracic outlet syndrome can be classified into three variants. It may be neurogenic. This is the first variant, which is by far the most common type or the most common presentation of the thoracic outlet syndrome. The most common nerve that is involved in the neurogenic variant of the thoracic outlet syndrome is the ulnar nerve with a root value of C8T1. Just once again, as Dr. Mohsin has told us, that T1, when this nerve is passing out, it has to curve, and ultimately it is very prone to get compressed over there. Got it? Remember that point? So this is what has happened here, that the commonest nerve or the nerve roots involved are C8T1. Then it may be venous, it may be arterial. Arterial is the rarest, and then ultimately it may be a mixture of these three. So what you need to remember here, that though the commonest variant of thoracic outlet syndrome is neurogenic, accounting for 95% of the cases, the reality is that any one of these structures are compressed with almost equal incidence. The only difference is, as the nerves are more prone to injuries, they are easily injured, and therefore the clinical presentation of nerves is more common, and hence the commonest presentation is neurogenic. So this was dependent upon which structure was compressed. Now, dependent on where the compression precipitates, this thoracic outlet syndrome can further be classified into three different variants dependent upon the area of compression. You remember the three main areas: the scalene triangle, the costoclavicular space, and the third one was the pectoralis minor space. So if the compression happens in the interscalene triangle or the scalene triangle, which you see here, this triangle, if the compression is happening here, then this is known as the scalenus anticus syndrome, and the structures compressed are the nerves and the artery, as the vein is not present in this area. The second variant of this syndrome is known as the Eden's syndrome or the costoclavicular syndrome. This is the compression in this costoclavicular area, the compression of the vein which passes through this area. And ultimately, the third variant is the compression over here in the pectoralis minor space. Now, what happens here is that when this muscle is passing or the nerves are passing below this area, when we raise the upper limb like this, these vessels and the nerves kink out over here, and ultimately they are compressed. When we hyperabduct the upper limb, and this leads to the compression of the nerve or the artery or the vein, and this is known as the hyperabduction syndrome. Got it? So three variants dependent upon the structures compressed, and three variants dependent upon where the compression took place. Fine. So once this has happened, the patient has presented to us what would be the presenting complaints and what are the reasons why this precipitates. By far, the most common cause of thoracic outlet syndrome is poor posture. Either you stand up like this or you sit like this, whatever. If your posture is wrong, you sleep like this with the upper limb abducted with a pillow over here below your head. All of these things can ultimately cause in the compression of the structures. So by far, the most common cause of the thoracic outlet syndrome is poor posture. Then this may be due to repetitive activities like the athletes or maybe the cricketers, when you have going for the ball, you move your upper limb like this in rotation. This is the same movement that the swimmers have to do. So repetitive activity may also lead to it. Once again, these two are mainly posture related. Then there may be some pathological reasons too for the thoracic outlet syndrome. Like we may have the cervical rib. Here in this first picture, you can see the cervical rib here. This is the cervical rib, which is compressing this subclavian artery over here above the first rib in the scalene triangle. The same way here also you can see the first rib, which is attached to the the cervical rib, which is attached to the first rib with the ligament over here. So this is the cervical rib. Okay. Then here also you can see in this 3D reconstruction using the investigations, this is our cervical rib, which is going out over here. This is our cervical rib, which may compress the structures here. So cervical rib may compress it. Then we may have anomalous long transverse process of the C7 vertebrae. Then this may be due to anomalous insertion of the scalenus anticus muscle, that this moves a little bit backward further, or this may be bifid, ultimately compressing these structures. Then this may also be due to trauma to this area. The further other important reasons that we may have is the fracture of the first rib, which may compress it. It may be due to tumors that may be present in this area, as we will see later on. A very important syndrome associated with the tumor compressing these structures here. Then this may also be due to abnormal bands and ligaments. Okay. So these are various reasons why the thoracic outlet syndrome precipitates, and among these, by far the commonest cause for the thoracic outlet syndrome is poor posture, most common cause. The clinical presentation of the thoracic outlet syndrome, no doubt, the commonest presentation is neurogenic, that there is pain and paresthesia in the distribution of the brachial plexus. And we already know that the most common nerve involved is the ulnar nerve. Okay, so remember these. Then furthermore, there's weakness in the affected upper limb. And once again, as I told you, that all of these structures, the artery, vein, and nerve, they are affected in almost equal frequency. But the clinical presentation, neurogenic features predominate. Then furthermore, we may have vascular compromise giving rise to features like we may have Raynaud's phenomena. Other features of arterial compromise like decreased temperature in the affected limb, cyanosis of the affected limb, especially when there is exertion of the upper limb, we are performing or we are doing exercise or something. This may precipitate. Claudication may precipitate of the upper limb. Ischemia, gangrene of the digit may precipitate. Then further along, we may have effort thrombosis of the subclavian vein. This effort thrombosis of the subclavian vein, which is known as Paget-Schroeder syndrome. This Paget-Schroeder syndrome is effort thrombosis of the subclavian vein, which is effort-induced thrombosis of the axillary vein or the subclavian vein due to compression of the subclavian vein, which happens in the thoracic outlet syndrome. Axillary vein is just a part and parcel of the subclavian vein. Actually, in the axilla, it is known as the axillary vein, and then it moves further towards the thorax, then it is known as the subclavian vein. Okay. So, effort thrombosis, Paget-Schroeder syndrome. So, once this has precipitated or presented to us, how to clinically test that thoracic outlet syndrome has precipitated or to make a clinical diagnosis. A few important clinical tests are done. One of these tests is known as the Roux test. Roux test is also known as the elevated arm stress test, or EAST for short, EAST, elevated arm stress test. It is also known as the hands up test. The patient is going to raise the arm to 90 degree of abduction here, 90 degree, and then this flexion over here of 90 degree, like this. And then we ask the patient to close and open the fist like this. And if the symptoms precipitate, it means that the patient may be having thoracic outlet syndrome. Though there may be some other reasons too, but most probable diagnosis, thoracic outlet syndrome. Then another test which is possible over here is known as the Adson's test, also known as the scalene test. Now what we do here is that we palpate the radial pulse over here. We ask the patient to extend the neck like this and then move the neck towards the affected side like this. And if there is a decrease in the radial pulse, it becomes weak, then it is a sign of thoracic outlet syndrome. And just the opposite of this may also be done, that you are palpating this area, the radial pulse, and you ask the patient to extend the neck and move towards the opposite side like this. This is what is known as the Halsted maneuver, reverse Adson's test, or the Halsted costoclavicular compression test. Doing this, we are palpating the radial pulse, we are compressing this area downwards, there is a pressure here, and then the patient is asked to move the neck opposite to the side of the clinical features. This is our Halsted maneuver. So Adson's test and the Halsted maneuver are just opposite to each other. Another test which is done here is known as the Wright's hyperabduction test, where the patient's arm is abducted 280 degrees like this. There is stretching over here. If it is present, then we will have a weakness in the radial pulse, right? And one last important test that can be done is known as the Eden's test, or the military brace test, or the exaggerated military position test. In this, what we do is that once the patient is sitting in the neutral position, then just as the army men, they stand in attention like this. This is what we are going to do. Ask the patient to extend the neck, move the arms, the shoulders upward like this, and move it backwards, and pull the hands backwards. If the patient is having thoracic outlet syndrome, then this is going to precipitate the clinical feature and the radial pulse is going to decrease. It will diminish. Okay. So this is our costoclavicular military brace or exaggerated military position test. Fine. So how to investigate it and how to manage it? The investigation involves a number of things, as we have seen that there are a number of etiologies. By far the commonest etiology is posture. We can take in the X-ray over here, which may show us this cervical rib here. MRI may be done. We had seen the 3D reconstruction. Cervical myelography may be done. Now, why we are doing all of these things is to rule out, RO means rule out the narrowing of the intervertebral foramen, or if there is a disc compression. Okay. Then we may perform the Doppler, color Doppler, vascular imaging like angiogram or venogram to check out for the involvement of the artery in the vein. And this is going to rule out if there is any aneurysm or thrombosis present. Then nerve conduction studies and electromyography may be done. This confirms the diagnosis of the neurogenic thoracic outlet syndrome. It localizes the area of compression, and it also rules out the carpal tunnel syndrome, CTS, carpal tunnel syndrome. And then comes the management. The management of the thoracic outlet syndrome most commonly is non-surgical, because the commonest cause is posture. So non-operative treatment is the most common treatment, as the most common cause is posture. We ask the patient to improve the posture. This is by far the most important component of management. Physiotherapy is done. You need to remember this, that the management of thoracic outlet syndrome is posture correction and physiotherapy, unless and until there is a specific pathology present. Then breathing exercises, avoid aggravating activities, avoid repetitive upper extremity mechanical work, like moving the upper limb like this. Then analgesics, muscle relaxants, and antidepressants may be given. When do we need to perform the surgery for? Specifically, if there is a pathology present which can be removed using surgery, we will go with surgery. The indications of surgery in the thoracic outlet syndrome. If the symptoms persist with non-operative management, if there is an associated vascular compression which may ultimately cause ischemic injury to the upper limb, go with surgery. If there is a progression and aggravation of the neurological features, if the nerve conduction velocity is less than 60 meters per second, and if there is some specific pathology like a cervical rib or tumor, etc. And the surgical management is to remove the offending pathology. So nothing much here. The main thing that to remember is the management of thoracic outlet syndrome mainly is posture correction and physiotherapy, right? So this is the whole about the thoracic outlet syndrome. The important points that you need to remember for the exam. First of all, the anatomical structure, which was explained to us by Dr. Mohsen, you have to remember it very clearly, because most of the questions are going in from the anatomy itself. The interscalene triangle, the costoclavicular space, and the pectoralis minor space, which structures enter through the inlet and what structures come out through the outlet. There are two things now, you remember? So this is the first thing you need to remember. Then the three variants: neurological, arterial or venous. Then the other three important classification, that it could be either the scalenus anticus syndrome, it could be costoclavicular Eden's syndrome, or it could be our hyperabduction syndrome. Then the stress thrombosis of the subclavian vein. This is what the question is. It is known as, or what is this syndrome? Like Paget-Schroeder syndrome, which is the stress thrombosis of the subclavian vein and the axillary vein. Then comes in the cervical rib, which you need to remember. And ultimately the management is posture correction and physiotherapy. A few important syndromes that are associated or giving the similar picture as the thoracic outlet syndrome, actually they are a part and parcel of it, is something known as the Pancoast syndrome. Now what happens in this Pancoast syndrome, that this is a clinical symptom or sign due to the compression of the brachial plexus over here, due to a postroapical tumor here in the superior sulcus. Now here in the superior sulcus, if there is a tumor, this will compress the lower trunks of the brachial plexus, and it will also compress the sympathetic chain here, that is kept, and ultimately gives features similar to thoracic outlet syndrome. This is what is known as the Pancoast syndrome. As you can see, a tumor over here, which is in the postroapical area of the lung. And this tumor is most commonly an adenocarcinoma. This tumor, as it is present in the superior sulcus, is known as the superior sulcus tumor. And as it causes the Pancoast syndrome, it is known as the Pancoast tumor. So this is Pancoast tumor or the superior sulcus tumor, giving rise to the Pancoast syndrome here. Okay, the most common nerve involved here also is the ulnar nerve, C8, T1. Similar to our thoracic outlet syndrome, everything is the same over here. Okay, and this compression of the sympathetic nerves over here that you can see, and this thing kept over here, this is our tumor. This tumor is compressing the brachial plexus and is also compressing this sympathetic nerves, and will precipitate the features on the same side, that is ipsilateral side. Just around here is kept the stellate ganglia of the sympathetic chain, which communicates with the brachial plexus by itself. So along with the brachial plexus, this stellate ganglia and the sympathetic nerves may also be compressed. Now, as you remember, the function of these sympathetic nerves, especially over here in the eye, that it causes the dilation of the pupil, sympathetic stimulation, fight and flight. It causes proptosis, that is the raising of the upper eyelids like this. Once this is gone, the eyelids will constrict, known as miosis, and this eyelid will come down, droop down like this. This is ptosis. Sympathetic supply also causes sweating. If the sympathetic supply is lost, sweating is lost, known as anhidrosis. So the three features of Horner syndrome are meiosis, ptosis, and anhydrosis. Okay. The other features that we have are pseudo features, not to be remembered. So compression of the stellate ganglia and the sympathetic nerves gives rise to Horner syndrome, clinically precipitating or presenting to us with ipsilateral ptosis, meiosis, and anhydrosis. The compression of the brachial plexus due to a tumor in the superior sulcus on the postroapical aspect of the lung, most commonly an adenocarcinoma, gives rise to Pancoast syndrome. The compression of the structures coming out through the thoracic outlet gives rise to thoracic outlet syndrome, which can be either scarinus anticus or costoclavicular or the hyperabduction syndrome. So this is it. One more picture over here. This tumor, you can see this tumor here. This is compressing the nerves over here, the stellate ganglia, the sympathetic nerve, the nerves of the brachial plexus, even the recurrent nerve over here is being compressed. The vagus, which is coming down from over here, this may also be affected with this tumor ultimately. So all of these structures, this is our Pancoast tumor. The same thing here also. This is the Pancoast tumor. You can see this is the first rib. This is the clavicle. These are all the roots of the brachial plexus, and the Pancoast tumor here is compressing this lowermost root. This is once again gadolinium fat suppressed T1 weighted image MRI, which is showing us over here. This is a sagittal, oblique sagittal view over here. This black area, whole area you see is the lung here. And just over here where you see this red mark, this area, this is where the tumor is. This tumor, which is compressing the brachial plexus and the sympathetic chain, and ultimately the clinical presentation over here, you can see that this is the drooping of the eyelid here, ptosis. So this is ipsilateral side, this precipitates. Okay, so remember that Horner syndrome, ipsilateral. Thoracic outlet syndrome, ipsilateral. Okay, when we go with the neurosurgery, we'll see that there are a lot of features that are going to be contralateral, and that would definitely be better explained to you in the anatomy itself. So that's it for the thoracic outlet syndrome and other important syndromes that may be associated with similar features like the Pancoast and the Horner syndrome. Once again, in the end, I'll suggest that you should join the Nextillo app. For the next 3 months, the access is being given at ₹89 only. This is due to a lot of conditions that are going on around like this in the whole world. The scenario, the economic scenario, and the war situation that we have, and that would help us, help you a lot, because we have all the 19 subjects, their videos and lectures present over there. So it is going to help you a lot in your preparation for your college exams and other competitive exams too. Thank you.
Thank you, sir.